This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any materials or techniques shown or described, nor does SimKit, its authors, and associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedural process in each individual patient. Hello, everybody. Hello, and welcome back. Welcome back to the SimKit podcast. I am excited, and I'd say in many ways I would be honored. I am honored to be joined by our guest today to talk about the cost of boarding. Our first guest is a familiar voice of the podcast, was my co-chief at Temple University Hospital, Dr. Schreyer. For those who remember, Crafton was our guest on the ED Crowding and Boarding podcast, which we'll link in the show notes. Crafton is an associate professor of emergency medicine at the Lewis Katz School of Medicine at Temple University, and ED medical director, ED administrative fellowship director, and medical director of capacity management, and the first author on the economics of an admission holding unit in WestGem. Crafton, welcome back to the show.
Thanks for having me back, Jay. I'm happy to be here.
Happy to have you. We have a second guest too, though. Our second guest is a new voice here for us at SimKit, one we are very proud to have on the podcast, Dr. Maureen Canellas. Dr. Canellas, who has granted me permission to call her Mo, is the first author on a recent paper that's been getting a pretty good amount of buzz, and we're going to be talking about a lot today. It is the measurement of cost of boarding in the emergency department using time-driven, activity-based costing in Annals of Emergency Medicine, October 2024. Mo, welcome to the show.
Thanks, Jason. I'm really excited to be here.
Very, very happy to have you both, and thank you guys for offering your expertise. So, Crafton and Mo, I'm going to start real high. We're going to start at the 10,000-foot view of the boarding issue in the American emergency departments, and why we might be in this pickle, and then kind of offer for you guys to expand on what I said. How's that sound?
Sounds great.
Yep, let's do it.
So, with our audience, we're largely emergency medicine providers. We know what boarding is. It's the practice of holding admitted patients in the emergency department. This is one of, if not the greatest contributors to crowding in emergency departments, which is in turn is associated with, we all know the problems, right? The ambulance diversions, the increase in our staff burnout. We feel it ourselves. We have prolonged hospital stays, increased risk of violence towards our staff when family members or patients are frustrated, decreases in patient satisfaction, increases in preventable medical errors. The list really goes on in terms of the untoward effects of boarding and crowding. In 2022, ACEP and other stakeholders wrote a letter to President Biden highlighting this public health emergency. Now, how did we get to where we are, and why have we not gotten ourselves out of this mess is really the subject of a lot of theory, a lot of pontification. One such theory outlined in this paper is that financial drivers are really to blame. Hospitals give preference for elective admissions, given a higher reimbursement rate, not leaving enough room for the influx of admits that come through our emergency departments. So understanding the financial drivers, and more importantly, the financial consequences of boarding, are really pretty necessary to get a full understanding, to get a full picture of what's going on and why we're here. So hence this paper. Mo and Crafton, how'd I do? Anything to add on the background for boarding and why we're here?
Yeah, I think you hit it right on the head there, Jason. The detrimental effects of boarding to patient care, throughput, and overall staff and patient satisfaction have been published numerous times over in the literature. Knowing that, we wanted to really round out the effects of boarding by evaluating the financial cost in a way that hadn't been fully explored previously.
Yep, I'd agree. And I think it's really important to highlight the financial aspects, as Mo mentioned, not only because it directly relates to the problems associated with boarding, but because it's important for communication with the C-suite. A lot of us are going to find ourselves in positions where we're talking about this issue outside of the department, and the C-suite primarily communicates in a financial language. That's really atypical for the regular physician, so highlighting that aspect is really key as we get to work on getting this problem solved.
Yeah, makes sense. We got to be able to talk the language if we're living in the problem, want to address the problem, all of the above. So now this article, it points out a prior meta-analysis in 2021, and it included a whopping two studies that analyze the financial implications of boarding. So a twofold question for you guys. What did this data show us, and why is the research so scant?
Well, overall, it really showed us that out of nearly 1,200 publications on boarding in the last 5 years, that only 2 really evaluated the financial costs. The first was in 2015 by Dias et al., which estimated about a $4 million benefit to their bottom line if they decreased average boarding per patient by only 60 minutes. The limitation here, however, was it was a highly simplified model with a lot of assumptions. Now, for the second study and why research is so scant, I'll leave it to Crafton here, who was the co-author on that second publication.
Yeah, we actually did our study back in 2017, also looking at the direct costs of boarding patients in the ED as it related both to staffing costs, operational costs, and then opportunity costs for the patients that weren't seen because of the boarders. As Mo noted, there are inherent costs associated with boarding that are important to identify, but it's tricky to get to those costs because it takes a lot of work to do these studies. And Mo's going to go into more details about how she was able to accomplish the great work that she and her team did. But it does take a lot of time and energy to get a study done that looks at true time-driven, activity-based cost of boarding, which is why I think that there is not much literature out there. And then I think, furthermore, if anyone's ever worked in a financial realm of hospital administration, you know that a lot of costs really aren't transparent. So a lot of assumptions have to be made, and that makes the conclusions a little tricky. But it's important that the work gets done, and I think Mo's really done a lot to add to this literature on this topic.
That makes a lot of sense. I think as a sort of, quote unquote layperson, if you think about the day in, day out of a hospital and how it's run and all the layers from, the utilities to staff to the EVS, there's so many layers to this onion that have to be peeled back to really understand the cost of an hour spent in the emergency department. That is impressive in that study to see $4 million benefit if you can decrease boarding by 60 minutes. But as you said, maybe just a little too superficial of an assessment of this really complex issue. So enter this study. Great. That's the study we're talking about today, is the measurement of cost of boarding in the emergency department using this time-driven, activity-based costing, again in Annals from October 2024. Now, this was a prospective observational study of patients admitted through the ED for acute stroke. I'll say that again, for acute stroke in a single large urban academic medical center. The primary outcome was the total cost per patient for med-surg boarders and inpatients, and ICU boarders and inpatients. Now, Mo, the paper explains stroke patients were chosen because they were easily recognized early in their emergency department care and had a high likelihood of being admitted, which makes sense. Are there any other caveats to the study design that our listeners should be aware of?
Yeah, I think in addition, acute stroke patients were chosen because they were really only admitted to one of 2 places in the hospital, one specific ICU and one specific floor. Thus, we could work with consistent staff. We could get buy-in a lot easier from all of the staff involved. They had consistent overhead and staff costs. In addition, stroke patients, not just stroke patients, but really you're getting an older population because those are code strokes who are likely getting admitted to a code stroke team. We also did a mix of direct observation, which is the gold standard of TDABC, along with surveys, which can lead to survey bias, but we can discuss that later.
Okay, perfect. And again, just as we use that acronym TDABC, that is that time-driven, activity-based costing. And I think you kind of answered my follow-up question in your initial, but just to confirm, there's the natural question, why not just look at all patient types and sort of hit them once that admit order button is placed in your EMR?
Oh yeah, that would be ideal and would be a study I would love to do if a large funding body wanted to give me more than the 100,000 that was generously given by MF and EMPI. But really to re-highlight what Crafton said earlier is that the sheer time and cost that it takes to do TDABC well and to do that within a $100,000 budget, which sounds like a lot, is incredibly difficult. We ended up with over 17 to 20 research assistants alone, watching patients 24/7 at their bedside, handing out surveys for several weeks. That costs money to do right. And if you expanded that to every single type of admitted patient, that just becomes unwieldy with the amount of money that we had in our budget.
Okay, yeah, that makes plenty of sense. And my goodness, that's a lot of research assistants, even just in that specific population. As you mentioned, I can't imagine how many would be required and the cost and the hours of observation to do all patient types. So thank you for explaining that for us a little further. And now, so as we get into the meat of this article and this topic a little bit more, I think, we're diving into it. We talked about its structure, where it's based, but one really, really important caveat I think to make in this is that this is in this hospital, boarding med-surg patients are cared for by the ED nurse and the admitting team. So boarding med-surg, the admitting team takes over care. Boarding ICU patients are cared for by the ED nurse, resident, and attending. So really important caveat to keep in mind as we kind of dissect this a little further. But let's start talking about cost. This study utilized a different cost analysis than prior work, and we've talked a little bit about it, this time-driven, activity-based costing. And as the paper points out, it's really pretty resource and time-intensive to do. Mo, if you would, help us non-financial people understand what this time-driven, activity-based costing is. What is it, and how does it differ from the prior work that was done that we mentioned earlier in this podcast?
Yeah, so the biggest thing to think about is this is costing. This is the cost of an activity. It is not your revenue, your profit, what the payers give you, or what the patient pays. So for example, Jay, if I want to sell you a burger, I can tell you it costs $1, but that might not be the true cost, right? I need to think about the cost of gas to drive my car to the store, the time cost on me at the store finding those groceries, the actual cost of buying the bun, the quarter pound of meat, the tablespoon of ketchup, et cetera, et cetera. Every activity that I perform in creating that burger that I say costs $1 takes X amount of time and costs Y dollars per minute. It's finding the X and the Y that is so difficult and time intensive and financially costly to us when we're doing research. So in this case, we worked extremely closely with our wonderful finance department, who really were quite transparent with costs and salaries. We were able to get our annual overhead cost for each care area, each staff member, each physician, etc. We then took all those costs and divided it by the exact number of minutes that each is available to work across each year. So that'll give you the exact dollar per minute cost of every resource that we followed. Then you simply, in a way, multiply that by the number of minutes each resource is spent on every patient. And that's where those research assistants, direct observations, and surveys come in. And voila. And you'd say it's simple, but it's incredibly time consuming and resource intensive. But it does get you that dollar per minute cost of boarding, or in our case, we multiplied it to get $1 per day. And that's TDABC. And the prior two studies did use TDABC, but the uniqueness of our study is the granularity that we were able to achieve. And again, I want to highlight the generous grant by the Emergency Medicine Foundation and the Emergency Medicine Policy Institute. We were able to hire almost 20 RAs to work 24/7 for those 4 weeks, sitting at that bedside, distributing surveys to get us that granular dollar per minute that I described. And I really want to thank them all for that.
I'll just jump in for a minute and say that the work that Mo's team did was really commendable here. The level of detail they were able to understand and how time-driven activity-based costing applied to their system is really incredible. We did look at it in our paper, as she mentioned, that was a few years ago, but it was definitely more of a superficial view. We didn't have as many resources as they were able to garner and didn't have the ability to devote the time and cost it requires to do the study in that much detail. The beauty of using the methodology, though, which I think should be used as often as it can in healthcare to evaluate costs, are that it attempts to account for, both operating costs, personnel costs, and all the costs really associated with patient care. It lets everyone see what costs are allocated at each step in the care process, and that's why it's so valuable.
That makes a lot of sense. And I appreciate the analogy and sort of breaking down all the elements of care. It's not just minutes in the department, there's so many pieces to the pie and to the puzzle. And it sounds like, Mo, you were really able to get a much higher powered microscope, if you will, and sort of dissecting and breaking this down and looking at the cellular, granular level of this complex problem or process. So awesome. Thank you guys for explaining that. So let's get into the results now. In the paper, there were 119 stroke activations, and that's in 4 weeks. First and foremost, that is insane. That's 4+ stroke activations per day. So of the 119, 50 were excluded as they occurred simultaneously, occurred at the same time as other stroke activations. With how busy that was, that makes a lot of sense. 16 were discharged, 19 were admitted to non-acute stroke services, 2 AMAs, 2 ED OBS, 5 thrombectomies, a partridge and a pear tree, leading to the 25 total included patients in the study. Mo, tell us about these stroke activation patients per day and kind of the exclusions that occurred during the study.
So yeah, just to echo what you said, those 4 stroke activations a day highlights just how busy our neurology service is and how great a job they do to manage all of those activations, their boarding patients and the inpatients that they're still responsible for every day. We're one of the only stroke centers in all of central Massachusetts, and they do an amazing job. So those 44 patients excluded due to discharge, admitted to non-stroke services, AMA, ED OBS, and thrombectomies just can't be avoided. We started following them the minute they came in the door. We weren't sure which way they were going to go. The 50 were excluded due to them overlapping with other activations. Comes down to just, again, the cost of doing TDABC correctly. Despite the funding we had, despite the number of RAs we had, we just couldn't make it work to see every single patient that came through as a code stroke activation. We wanted to do this well, and we wanted to do it correctly. So we wanted to get the best data we could with the limitations we had. I was also on call 24/7 for those 4 weeks, along with 2 of my colleagues. So when an activation came through while the RA was observing another patient, they would call me or one of my colleagues. We'd discuss which patient was more likely to be admitted to a stroke service and how many hours of observation they had already collected on the current patient. It was all very case by case in an attempt to ensure we had the most data for the most number of patients possible within our study timeframe.
Wow. Well, thank you for doing that. Thank you for being on call during that time frame, you and your colleague, and all the hours put in by the research assistants. And it makes a lot of sense in terms of the drop-off and the total number of patients. So in the end, we have our 25 patients. Not to oversimplify this process, but basically once they were identified, researchers sat at the patient's room or outside the patient's room and documented medical provider care in the ER and either hand-delivered or sent out surveys related to care not completed at the bedside. On the ward and in the ICU, care providers completed the same surveys on all the elements of patient care provided. Mo, tell us about this process a little bit, and is there any risk of bias related to the lack of direct observation for those non-boarding patients?
Yeah, certainly there's that risk of bias. However, one of our collaborators in the manuscript who's mentioned in the acknowledgements is Dr. Robert Kaplan, who's one of the 2 creators of TDABC over 20 years ago. Their approved methodology for TDABC is that while direct observation is the gold standard, contemporaneous, structured self-reporting is sufficient when necessary. So we decided that given the more consistent workflow and geographic type of care that occurs on the inpatient floors in ICU compared to that in the ED, we determined that direct observation was better served in the ED and surveys were more appropriate for the floor, where they have less turnover of staff and resident teams because they're typically Q12 hours. There was more consistent day-to-day workflow and more consistent round structures. In an ideal state, direct observation would be 100% across all patients, all care areas, and all disease states. But I'm going to need somebody, maybe like AHRQ, who just had a new RFA come out about boarding and finances, to give me a lot more money to do that research project.
Another hint toward giving some more funding to these fantastic researchers. We just got to get this podcast out, distributed to those individuals for you, Mo, and get you that money. How's that sound?
Yes, please do.
We'll work on it. All right. So in the end, there were these 25 encounters, and this included 564 hours of ED boarding. 564 hours in 25 encounters. That's an average of 22 and a half hours per patient. That is a lot. Mo, tell us about how this broke down. Did we have some patients go upstairs right away and others board for multiple days?
Yeah, unfortunately, med-surg boarded on average 1.5 days. Some patients only did for 5 hours, others for almost 5 days. ICU boarders were luckier, if that's even the appropriate word here. They boarded on average just under 1 day. Again, some only for 5 hours, the most only for 3 days.
Yeah, I'll just jump in again and add that, I don't think, as Mo said, no one's really lucky in this scenario. No, we're all unhappy with the time that boarders are spending in the ED. And as a result, I think they're getting worse care. In our paper, we looked at actually how those care minutes were spent for the patients that stayed in the ED after their admission was placed. And there was a sharp decline in interactions with the boarding patients, both from a physician and nurse's perspective. So initially, in the first 30 minutes, patients got an interaction of 2.5 to 2.8 times on average by a member of the care team. But that quickly declined to 0 from anyone, an hour or more after disposition. So not only is the time costing a lot, but it contains a lot of non-value added activities.
Wow. And that's interesting and worth probably even saying again, once someone's put into that boarding state, 2.5 to 2.8 contact points in that first 30 minutes, and then see you later. I'm going to continue to provide care for the emergency department patients that are checking in, need stabilization, etc. So after 1 hour after disposition, that drops to 0. So we all know that problem. We all know a bit of why we are where we are, how we are there. But important to highlight that this is a recognizable trend. Once someone has that admit order in, there's a grain against going into continuing to provide care. So let's get into the meat of the results for this paper. Now, I broke them down a little bit into tables, which are included in the show notes for everybody to review. Let's just talk about cost, global picture of cost. We have our boarders and inpatients. We have our med-surg and our ICU. So for med-surg, the boarding patients had an average cost of $1,856, inpatient $993. Not quite twice for the ED boarder. For the ICU, it was $2,267 for a boarder, and for an inpatient, it was $2,165. Relatively comparable numbers there. And now this is without looking at travel nurses, which post-pandemic we're all very familiar with, and is a more prominent issue or presence, I guess you'd say, in the ED in many places. When you consider travelers and their cost, the numbers were similar, but a little bit worse in terms of that cost disparity between an inpatient and a boarder. So now to understand these cost differences, we need to break it down, right? We need to break down kind of the layers of the onion like we talked about with that burger analogy. Let's look at the components of care that led to these costs. And I'd like to start with personnel, if that's okay. So first, we're going to look at the nurses. We see that ED nurses cost a little bit more than a med-surg nurse, but they spent on average 21 minutes less time with the patients. So less time with patients, more cost. For ICU, ED nurses' total cost was quite a bit less than the ICU nurses' total cost, but on average, they spent less time by 6 hours per patient than their ICU colleagues. Team, kind of what insights can you offer on the nursing costs that we see here?
Yeah, so for the financial side, you're seeing that ICU nurses cost on par with ED nurse costs. So really, when you compare inpatients, med-surg inpatients, and boarders, you're using the more expensive nurse to board med-surg patients. You're using that ED nurse cost. It's essentially like you're boarding patients on purpose in an ICU and accepting those increased costs. Hence, the larger nursing numbers you see there. In terms of the difference in time spent, ED nurses did, I agree, have less time on average spent with their patients, specifically for ICU patients. But really what we look at here is the ratios, the patient ratios that our nurses have set up. The M&A, our nursing union, does not have set ratios for ED nurses for patients. They, however, do have set ratios in their contracts for ICU and floor patients. I'm not saying that that needs to change, that this paper says that needs to change, but it does explain the difference in care time you're seeing. ICU nurses were able to spend about half their entire shift with each patient. They had a 2-to-1 ratio or a 1-to-1 ratio. And when you look at the ED nurses, they were spending about a quarter of a shift with every ICU patient, which makes sense because they typically have 4-to-1 ratios, if not higher. So really what you're seeing is not that the ED nurses didn't want to care for these patients more, that they might not have needed more care, but that they simply had ratios in place forcing them to spend less time with those patients.
Yeah, I was just going to add a quick comment with regards to the nursing costs. There's a trend that I'm seeing nationally that I think is highlighted by the findings in the study, and that's that inpatient resources are sometimes diverted to the ED. So as Mo mentioned, the ratios are often not the same for nursing care in the cost comparable areas like the ICU and the ED. So what we're seeing is ICU nurses sent to the ED to work within their ICU ratios. That would then free up the ED nurses to do ED care. And I think that's something that's implied by the findings in the study, and probably should be considered on a broader basis as we look for solutions to the boarding problem. Although admittedly, that's probably not a sustainable solution and seems like more of a Band-Aid.
Mm-hmm. Yeah, just kind of finger in the dam, right? As our nurses are overrun. Unfortunately, our nurses don't have that protected ratio, and that comes up commonly as we talk about, this overcrowding, overboarding, and protecting our upstairs nurses at the expense of our downstairs nurses. And as Crafton mentioned, if you bring some upstairs nurses down to help with the bleeding, to help make things tolerable and survivable, it's not a real solution to the problem, but it's complex and it's worth noting. And those ratios are important to keep in mind as we look at those costs. So let's talk a little bit about physicians. Now, this one's a little bit more complex, a little bit harder to kind of package into a nice little nugget, but we're going to just look at the time. And we know the costs per hour as Mo broke down. Let's first look at the physicians in the emergency department. So we have the med-surg boarder and the ICU boarder, and we have our attendings and residents. So remember again that caveat that when a boarder in this hospital is admitted to a med-surg, they are generally technically transitioned to the med-surg care team, where ICU patients are still thought to have the ED team as a primary provider of care. So for the ED staff, the attending spent 9 minutes with a med-surg boarder and 24 minutes with an ICU boarder. The ED resident spent 12 with the med-surg boarder and 37 with the ICU boarder. And again, those numbers make sense as the ED team is kind of responsible in many ways for these ICU boarders until they are upstairs. Now looking at the neurology team, the attending and resident. So for med-surg boarders, the attending spent 25 minutes, and for the med-surg inpatient, 62. Resident was 52 minutes for the med-surg boarder and 90 for the med-surg inpatient. When we got to the ICU patients, we saw the attending spent 47 with the ICU boarder and 49 with the inpatient, pretty comparable. And then the resident, 92 and 109 for the ICU boarder and inpatient, respectively. These numbers and tables will be in the show notes. I think globally, thinking about this, when we look at this cost of care, it tracks pretty well with the time spent. I think that's the take home here for me. Matches up with the amount of time the provider's spending. Neuroattending's cost for ICU patient care looks pretty equal and matches with the 47 minutes spent on ICU boarders and 49 spent with ICU inpatients. With med-surg, the neuroattending cost for inpatient was quite a bit higher, but they spent 2.5 times more time with the patient. So factor in the ED attending cost on the boarders, and we're pretty much equal. It seems to be largely a wash when we look at the physician costs of care and time. Is that accurate to say?
Yeah, that's a completely fair conclusion. However, despite this being a cost study, we really realized that the main insight here was less about the cost and more about showing the inefficient overlap in care of boarders. We have a very clear protocol where admitting teams are in charge of their med-surg boarding patients. This ensures that there aren't too many cooks in the kitchen, if you were. But despite this, ED physicians are still being pulled into the patient's care for various reasons instead. But as you said, it's quite a small amount of time and evens out cost-wise.
And I'll just chime in again and say that we're also fortunate that we have clear protocols for admissions to med-surg, and more recently a clear protocol for handoffs for the ICU patients. But there is a lot of variability out there in the US in terms of what different health systems are doing and who's caring for the patients in what location, and therefore what kind of care they're really being provided. So I think that the overlap that Mo highlighted is really important here, because you don't want to create excess waste by having people duplicate efforts. You want to really delineate that care process and have clear protocols so you can maintain patient safety and quality, which is really the most important thing.
Gotcha. And that makes a lot of sense. And I think it is, again, important to highlight some of those inefficient overlaps, which also can sometimes drive us ED providers a little crazy, right? So if we have a boarding med-surg patient and the nurse comes in and says, oh, the family would like an update, and like, well, that should really be the upstairs providers, but we got to find them, or the EKGs resulted and you got to take a peek at it, or why did we order this medication? Well, that wasn't ordered by us, it was by the inpatient care team. We can see many of those, one, task interruptions for us as providers, and two, those sort of inefficient overlaps where we have several cooks in the kitchen. So trying to improve upon that would definitely be an opportunity for cost reduction and improvement of our flow and interruptions as ED team. So for nurses, we looked at that cost and saw that basically we should be thinking about a med-surg boarder in the emergency department being charged really to board in an ICU level, right, with our nursing cost there. When we looked at the physicians, we saw that things were pretty much a wash. We saw some inefficiencies and overlap, but the amount of time spent matched up and laid out pretty well. With that in mind, it kind of begs the question, really, where does the increased cost of boarding patients come from? Well, if we look at the figure 4 in Mo's article, it looks like it's pretty much operational costs or operating costs that drive this. The operating cost for the ICU was comparable to the ED. And we see this reflected in the average cost per day per patient, right? Comparable for the ICU, way more expensive for the ED. The med-surg cost was way, way lower than in the emergency department. So is that a fair conclusion? Is it really this operating cost that's largely driving the difference we see?
Oh, absolutely, certainly. The ED is an expensive place. We're meant to be able to handle the most critically ill patients at any given moment. So it makes sense that its overhead is similar to that of an ICU. In a way, part of how we should look at boarding is that if you had an open bed in the ICU, would you ever consider putting a med-surg patient in that bed? That would be audacious. They would immediately shut you down. No administrator would allow that. But that's essentially what you're doing when you're using a critical care /ED bed to hold a med-surg patient who is not critically ill.
I completely agree with what Mo is saying. It's really a misallocation of resources to have a non-critically ill patient boarding in the ICU or in the ED, which is basically serving as a critical care area. And I'll just add that while it wasn't the focus of this paper, and we were able to dive into it a little bit in ours, there's an opportunity cost for those patients that can't be seen because of these boarders. And that also needs to be accounted for. A lot of those patients that are leaving, walking out of our waiting rooms because of boarding are potentially critically ill. And we don't have the space to take care for them. So it's really important that we are using the resources that we have in optimal ways so that all the patients can get the best care.
Yeah, that makes sense. And it adds even another wrinkle, another ingredient to that burger in that opportunity cost, right? The number of patients that could have been moved through that bed in the 5 hours to a day and a half that you're having someone board, that's money, obviously, that could come into the hospital through charging of insurance and the avoidance of the medical legal risk of patients leaving AMA or not even being seen and deteriorating at home. So even more complexity to this. Okay, so let's sum up the findings that we've gone over here. And then really what I want to talk in the closing minutes is about what we do. What do we do with this data? The cost per patient per day for an ICU boarder versus an ICU patient, inpatient, was basically the same. A little more for ED care, but relatively a wash. For the med-surg patients, the cost of boarding was roughly 2 times higher than that for inpatient care. And we saw less time spent by the nurse per patient in the ED borders than for inpatient nurses. The major driver for this disparity of cost is the operating cost between the two locations. Mo, Crafton, anything to add to those findings and conclusions?
Yeah, one additional point is that their care time by nursing and specialty physician teams are not equitable time-wise between boarders and inpatient. So as you said, ICU boarders experience 6 hours in nursing care time, and med-surg boarders experience less overall care time with the neurologists. So the patient is boarding in the more expensive area and experiencing less overall care times from their specialists compared to their inpatient counterparts. It ends up as kind of a double whammy.
Good point to highlight. Yeah, thank you. So with that in mind, and we see unfolded in these articles the problem, right? The inequity of care, the inefficiency of care. Mo et al., tell us, if you will, as your captive audience here, what do you think we as individual providers should take away from your paper, and what can we as a healthcare system, what should we be doing with this information?
Shay, that is the million-dollar question, or as some studies point out, maybe the several million-dollar question. At the end of the day, people just need to be aware that the true cost of boarding is poorer patient care, poor patient throughput, poor general staff and patient satisfaction. And now we're adding this financial burden as well. What to do with the information, I'm not sure. I just think we need to add these negative dollar signs into the conversation from now on.
So yeah, I think, as Mo put it, it's really a several million-dollar question. I think the most important thing about getting this type of data is that it facilitates communication with the C-suite and with leaders that can help enact change. In my opinion, there are a lot of ways to address this problem that have been highlighted in some other work that's been done on borders. I think the ideal is more space, right? So expanding inpatient capacity to care for the borders at a financially lower cost than in the ED, but that's quite an undertaking to expand capacity of a health system. So maybe not an option. As we talked about, diverting resources to the ED, perhaps in the form of nurses is another option, but more likely a short-term solution than one that's sustainable. I think the penultimate goal is probably providing ideal, effective, and efficient care for patients, getting them in the system, cared for and out of the system in a timely but, safe way. And I think finally aligning the inpatient, C-suite type of incentives with the ones that we're having on the ground floor is really the key that's needed. Above my pay grade, but I think that's the longer term solution. And then finally, I'll just put a plug in for accounting for that opportunity cost. The patients that are leaving, not getting cared for as a result of borders, that's real and it's not acceptable. The opportunity cost is probably higher than it was back in 2017 when we estimated it. And we need to do better for those patients. Getting more studies like this one that Mo did out there can only help us and further the cause to get the appropriate care for patients through the entirety of their spectrum of time in the health system.
That all makes sense. And I appreciate that call to action, at least for further research and interest in delving into this more, to really peeling back the layers, to figuring out exactly how much that burger costs to make. And I'm going to volunteer, Mo. If people have an interest in this topic, want to do research in the area, reach out to me and I can connect you guys in that space, because it's an area where we need more data. This data, thank you again, Mo and Crafton, for the work that you've done in sort of increasing the clarity of the lens that we look at this problem through. But there's still more to come. There's still more that needs to be done to really flesh it out and understand it. For me, I think one of the major takeaways, which we mentioned very early and somewhat briefly in the introduction, is we need to be able to speak the language of the people who fix the problem. We live with the problem on a day-to-day basis. We feel the effects of it. We feel it weighing on us and affecting our ability to provide quality care, maintain patient satisfactions. It sucks when you are doing a fantastic job caring for someone and they are dissatisfied because they are waiting for a bed upstairs for X number of hours to X number of days. That weighs on us as providers. And so if you're interested in the topic, one, take this paper and take this podcast and learn the language and present it to your C-suite. Make sure they are engaged, that they are aware of this work that's done, and that they're thinking about this. When they're considering how many surgical short stay patients are having on a Monday, are they triple booking above that capacity and overflowing into the inpatient setting? Are they recognizing that now anyone that would have been in that bed is now in the ED getting, ICU level care without being able to charge for that level of care, that quality of care? Things that we need to think about as providers, bring to our C-suite, make sure that they are asking themselves these questions, and by being armed with this data, this paper, and hopefully this podcast, you can bring this to, the local emergency department near you. So with that, you guys have any final thoughts, any last bits of wisdom or things you want to relay to our audience before we conclude?
No, that was great, Jay. I think the biggest thing is, I'm more than happy to talk to anyone who's interested, who wants to partner on it, just talk more. It's something I'm obviously very passionate about, and it's been about 5 years in the making, this kind of study. Reach out to Jay, and I'm happy to chat.
Likewise, I think thanks, Jay, for calling attention to this, highlighting Mo's work. And if anyone else is interested, we're here to help.
Awesome. Well, thank you guys so much for your time, your expertise. Again, in the show notes, we have some of those tables that we reference for the numbers related to hours spent, time spent, etc. And until next time, guys, thank you for listening. Bring this to your department and hopefully inform your C-suite to make educated decisions about the cost of care and particularly the cost of boarding. Till next time, guys. All right, y'all, do not forget SimKit and our mission of bringing procedural confidence and competence to emergency practitioners for high acuity, low occurrence procedures through simulation that delivers right to your door. Check out the link below for more.